Okay, so it is 5 p.m. here in Kumasi, Ghana. That's GMT, and I believe, depending on your time zone, if it's South Africa, it should be 7 p.m. on the dot. And you are all welcome to this maiden webinar, and I'm so excited. My name is Elliot Krantintano, and I'm the chair of the Young Nephrologist Committee, and it's exciting to be the chair of this program, which is the maiden one. And why this came about is that together with the education committee of the AFRAN, we decided that it's good for us young nephrologists to interact with the experts, so we brought up this name, case presentation to the experts. The whole idea is that we would see interesting cases in our clinics. And as I say this, I'm throwing it out to you, young nephrologists, or anybody who is interested to do this the next time, because this is going to be recurring. That any case of interest that you see in your hospital, please don't enjoy it alone. We want to hear that case. And we'll get an expert on board who would also guide us, as to how best we can see or manage our patients. So it's actually a learning curve, and I'm excited today because we have one of our great professors on the continent to help us out. So without much ado, definitely in as much as 2 or 3 are gathered, we need to have some rules, or else, everything will be in disarray. So the housekeeping rules are up for all of us to read, and I'll just run you through it. So basically, it's going to be very exciting. The skeleton in the closet, I have no idea. I've not gone into that closet, so I don't know what is in there. And I'm hoping our presenter and our expert will run us through this skeleton in the closet, and whatever is hidden so far as CKD, MBD is concerned, we are going to learn about it. So please, as much as possible, you can join, but please be quiet. I mean, if you disrupt us, it will disrupt the presenters, it will disrupt the whole program. And as much as possible, don't be in a noisy environment, which would disrupt everything. And make sure your microphone is always muted as much as possible, and the camera should also be off. We are on the panel allowed to show you our faces, but you can hide your faces for now. But we would want to hear from you, would want to read from you as we get along in the course of it. And the chat box is also available. So the Q&A, please, you can throw in your questions. In as much as you have a question in the course of the presentation, don't hesitate. We want to hear from you. You can even let us know where you are or introduce yourself so we can keep that chat also interactive. So that chat box is available. Throw your comments in, throw your questions in, and we'll be happy to have you. So like I said, my name is Elliot, and I'll be running the show with my co-chair, and she is Bianca Davidson. She's a fantastic lady. You're going to hear more about her sooner than later. She's also part of the Young Nephrologist Committee. In fact, she married the two together. So the Young Nephrologist Committee she's part of, and she's also part of the Educational Committee. And she's done such a yeoman's job to get this thing going. So you'll be hearing from Bianca very soon. You can see her beautiful face already. So without wasting much time, I'm going to throw in our first presentation. And indeed, it's actually going to be the case in itself, which we are going to hear from a very good friend of mine. Indeed, I've known Eric. I mean, he is Aristide, Eric Nono. In fact, the first time we met was, I think, somewhere in Mexico in 2018 or so. And ever since, we've been interacting one way or the other. So he's actually going to give us the case, which we are going to discuss basically. So Eric is actually an ISN fellow. And indeed, Eric happens to be, like I said, a fantastic nephrologist in Cameroon. And indeed, he's not missed. I'm not sure. I have a feeling, except for the one that was canceled because of COVID, he's not missed any of the ISN programs so far as I know of, because he's an active member. And indeed, we had to push Eric with a short notice to get this done. And he didn't hesitate at all. He came up with a case, and he lets me know that even the patient we are going to discuss is excited to know what we are going to do, basically. So your inputs are also welcome to see how best we can help this patient. So he's an internist, he's an ISN fellow. He works at the Yaoundé General Hospital in Cameroon. He's a temporary lecturer of the Higher Institute of Medical Technologies in Yaoundé. He's interested in CKD, MBD, and he's also interested in international nephrology and transplantation. He happens to also be the Deputy General Secretary of the Cameroon Society of Nephrology. So without wasting much time, I will throw the mic now at Dr. Aristide Eric Nono to give us the presentation. Thank you very much.
Oh. Hi, everybody. I hope everybody's getting me. Thanks, Eliot, for your presentation. Thanks to Professor Wen to have accepted to help us in this case. Thanks to Dr. Bianca that contacted me some weeks ago, and I was very happy to present this case because, as you said, this patient is really waiting for a solution, to find a solution for our case. So, without wasting time, let us talk about this young lady. Is Miss D.A. She's 31 years old. She's a medical secretary. She was diagnosed with kidney failure in January 2011. The cause should be, we thought of chronic glomerulonephritis. She came very late, so it's very difficult to be sure that it was chronic glomerulonephritis, but she came with very severe hypertension, edema, and as she was 20 years old at that moment, we thought this could be the cause. So finally, she started conventional hemodialysis twice weekly in April 2011. In her past medical history, there's nothing relevant before that event. She has 8 brothers and sisters who are all well. Her father is hypertensive and also has diabetes. Her dialysis protocol is twice weekly. She will use a polysulfone membrane, 1.6 meters square. The blood flow is always around 300 milliliters per minute. The dialysis flow is 500 milliliters per minute, and we use as anticoagulant sodium ipharinate, and her usual interdialytic weight gain is between 2 and 2.5 liter. Her dry weight is 50 kilograms. She tolerates well her dialysis sessions. So she was diagnosed in 2011, as I said, with a PTH level at the moment of the diagnosis at 1,500 picogram per milliliters. Don't worry, I will give those values in the spreadsheet later in picogram per picomole per liter, so everybody can find itself in this case. So from the beginning, calcium and phosphate were normal. The vitamin D level wasn't done. In 2015, she started complaining of bone pains, especially at the knee and ankle pains. At the moment, calcium and phosphate were also normal. PTH level, unfortunately, weren't done. But we started her on alpha calcidol that it was taking intermittently because the medicine is not really readily available in our context, and it's very expensive. In 2017, the bone pain was still there. The PTH level raised to 3,800 picograms per milliliter. We started her on sinacalcet and continued with alpha calcidol. All those medications were also intermittent because of the availability and price. In 2018, she presented a left clavicle fracture. The PTH level was still at the same level. At the moment, as sinacalcet and alpha calcidol were very difficult to be available, we decided to contact an ENT surgeon for a parathyroidectomy. He did an ultrasound, anterior neck ultrasound, and he decided together to remove both superior glands because they were the two that were enlarged on the ultrasound. At that time, scintigraphy was not done, though it was available in a different town from where the patient were living at the time. After the parathyroidectomy, no hypercalcemia was noted, so we didn't happen to supplement her with calcium, but there was no improvement in pains. In 2019, we noticed that the PTH level started to drop, but pains continue to worsen, and we start having some bone deformities, especially on the jaw, on the back. So we started having hip pain, but the X-ray we did at that time seemed normal, especially the bone density, and there's no lesions, there was no fracture. So she continued on sinacalcet and alpha calcidol when it was available, and we started her on painkillers. And the ENT surgeon said that he wouldn't go back to the surgery without scintigraphy to be sure of what we're going to do. So this year, in 2021, she had another fracture of the right clavicle. The pains are worsening, they are constant, and she's really have moving difficulties. She's limping, and these pains are really impacting her quality of life. And on the X-ray, a different X-ray we did, the bone density are still normal, and there are no fractures. So we started painkiller escalation. Went to morphine because she was having constant, very painful pains. But the PTH level seemed to get down. It was at 955 picogram per milliliter with calcium and phosphate always normal. So our current treatment now is alpha calcidol, sinacalcet, when she can afford them. She's on native vitamin D, 100,000 units a month. She's taking EPO. She's constantly on paracetamol 3 grams a day. Finally, we had to stop morphine because of side effects, and she's taking tramadol 50 milligrams 3 times a day. Since this is already that's more than 1 year that she's taking this drug constantly. So this is a spreadsheet just to present you all the different, to resume all what I've said. And here we see that from 2011, when we had diagnosis, the PTH level was at 159 picogram per liter. It rose to 413 picomole per liter in 2018 when she had that clavicle fracture, severe bone pain. And after the surgery, the PTH level went to 132 picomoles per liter. But she continued having severe pains. You can also see that the PTH level now has continued to decrease. Now it's at 109 picomoles per liter, but the patient is still very painful, and these new fractures that she's having, and really her quality of life is very poor at the moment. It's constantly on tramadol and paracetamol. So these are some of her X-ray in 2019, just to show you here the left fracture clavicle that she had in 2019. This X-ray was done 1 year after the fracture. And this is the cervical X-ray to show you that there's no fracture here, and according to our radiologist, the bone density is also normal. And in 2011 and 2021, this year, this is the pelvic X-ray we did when she started limping a lot with those pains. And according also to our radiologist, this pelvic X-ray was normal in terms of bone density, and there was no fracture visible. So our question now is, what else can we do for this patient? What's our way forward? We have no scintigraphy available in the country at the moment. Sinacalcet and alpha calcidol are not really readily available, and they are too expensive. Should we do a parathyroidectomy of the 2 remaining glands without even the scintigraphy? And the last question is, what could we have done for this patient not to reach this very difficult situation for us? So from here, I really thank you for your kind attention, and really hope that with this discussion, we find a solution for this patient. Thank you, Elliot. Thank you, Bianca. Thank you, everyone.
All right. Thank you very much, Eric. That's a fantastic presentation. And indeed, mineral bone disease is actually indeed the nephrologist's nightmare. And it's exciting that today we are having this discussion, and happens to be the maiden one to be able to get into this, because trust me, we all struggle with these. Your patients are coming with all sorts of complications, and your hands are virtually tied at your back. And indeed, in Africa, where most hospitals don't have the luxury of even medications and luxury of investigations, it's such a difficult one to manage. So we are hoping to get answers, and to help us get answers is no other person than our own professor, indeed. I mean, Prof. Nikki would not remember, but the first time I saw Nikki was somewhere in South Africa, somewhere 2015, she wouldn't remember. I was like, this fantastic young nephrologist was delivering powerfully some HIV topic. And indeed, I was really captivated by her passion in what she does. So when I got to know that, well, she's coming to deliver on this, I knew it's actually the best aspect to have on this topic so far as we are concerned. So without wasting much time, I would introduce Professor Nikki Wayne. So she is an associate professor and a consultant nephrologist at Grootes Schuur Hospital in Cape Town. She is the head of the chronic peritoneal dialysis and HIV kidney clinic in the division. She has published widely, like I said, on HIV, and I was privileged to hear some of her publications so far as HIV is concerned, somewhere in 2015 and subsequently on AFRAN platforms. Due to the restriction on dialysis availability and all in Africa, she has been involved in advocacy. And indeed, that's why when she speaks with a lot of passion. Without wasting much time, I'll throw the mic to Professor Nicola Wayne to help Nuno, myself, and all you on the platform on how best to manage a case like this. So thank you very much, Prof, for making the time your audience. Thank you.
Thanks, Elliot, for your very kind introduction. I actually do remember meeting you, I'm going to say, and I will never forget that smile. I just want to say, Eric, this was a very complicated case. I'm going to go through my presentation. I really encourage people to ask questions. I have my own ideas, but there's no right or wrong here. So I'm going to go through, and I also want to just add, as Elliot said, some of these drugs are prohibitively expensive. So, you know, that also is very, very difficult. So I'm just going to go through CKD, BMD, and I'm going to try and direct the discussion towards your case. And then I think we can have a discussion about what is some of the ideas that could be done, or what should have been done, or, you know, we can discuss it. But I really encourage the conversation. So I'm just going to take us all back that progressive chronic kidney disease leads to secondary hyperparathyroidism. And we know that this hyperparathyroidism is driven by predominantly decreased calcium, but let's not forget increased phosphate, very important, as well as low levels of vitamin D. And all of these three things contribute significantly to increased PTH. And we can't deal with anyone, they must all be dealt with. So I like to go through this in a nice organized way. So decreased calcium and increased phosphate, which we commonly see in CKD, leads to increased parathyroid hormone secretion, which then does a couple of things. I always teach my registrars, PTH does three things. It stimulates bone resorption, very important in this case. It also causes calcium reabsorption in the kidney, and it promotes phosphate dumping by the kidney. And importantly, it activates vitamin D by activating 1-alpha hydroxylase in the kidney. By activating 1-alpha hydroxylase, we convert 25 hydroxy vitamin D to 125 dihydroxy vitamin D. Then what vitamin D does, it does three things. Firstly, it increases calcium and phosphate absorption from the gut. It stimulates, once again, bone reabsorption, but very importantly, it switches off parathyroid hormone. And that is why 1-alpha vitamin D is very important to help switch off PTH. I also just want to remind ourselves, all of us, that if we don't have the substrate in the beginning, if we don't have enough vitamin D or cholecalciferol, which comes from animal-based sources, we then have no substrate to actually produce the active form of vitamin D, the 125 form. So as we are all very aware as nephrologists, when we have all of these things going on, we also start to see glandular hyperplasia as we progress through secondary hyperparathyroidism with early nodularity and then we move on to quite nodular parathyroid glands. We also have decreased sensitivity to vitamin D receptors and calcium receptors. And ultimately, we have poorly or uncontrolled secondary hyperparathyroidism. And we don't usually use the term these days of tertiary hyperparathyroidism, but by this stage, our secondary hyperparathyroidism has become autonomous. It's doing its own thing without stimulation. This is an extremely important graph. We know that the mortality, there's a J-shaped curve when it comes to mortality risk and PTH, very important. So at very low PTHs, our mortality is increased. And as our PTH rises, our mortality increases. And what KDIGO recommends is that there's sort of a range between 2 to 9 times the upper limit of normal of your assay. That is what we recommend as, well, I would say safe, but the recommendation is to remain within those targets. And I want to explain why this J-shaped curve appears. But actually, Professor Swanepoel, who taught me, would actually say that low PTH may be even more dangerous than high PTH, so for different reasons. So I'm going to come to that in a moment. So there's an extremely important relationship between increased PTH and or high turnover bone disease, which is what I believe this patient has, or low turnover bone disease where the PTH is low. Both of them have different problems and manifest differently, although in some respects and in some ways the same. I'm going to start with our high turnover bone disease, but the bottom line is with that is that calcium and phosphate comes out of bone. It's in the serum milieu. Okay, so bone is resorbed. So there's a problem with bone resorption. If we have low turnover bone disease, we have too little PTH, and PTH is required for calcium and phosphate to actually be reabsorbed into bone. Very, very important. But both of them mean that there is a calcium phosphate milieu in the serum. So I love these pictures. And very importantly, I just like to show you that this is the bone that we're seeing there, the blue. And here you can see the osteoclasts, which have been activated by PTH, which are causing bone chomping. And we're actually seeing the bone eaten away, the bone resorption. Very important. These osteoclasts are going on a field day and they're chomping away at the bone. And here you can see in the digits of the top of these phalanges, you see bone resorption at the top here, classical picture of hyperparathyroidism and high turnover bone disease driven by osteoclastic activation. And on that point, and I just want to, I'm not quite the same as the picture that Eric showed, but I did want to show you that this is one of the classic places where one sees this bone resorption. And if we look at the symphysis pubis in this bone, you can see bone resorption here, which is also a marker of bone resorption from too much PTH or high turnover bone disease. Brown tumors are caused from the same problem, and they're caused by alterations in the trabecular bone pattern, demineralization, and replacement by loose connective tissue. They present as uni or multilocular radiolucencies, and here we can see them in the jaw. And I know that Eric spoke of the jaw pain in the one patient, in our patient, and or mixed lesions with bone expansion and bone deformities. And here's another example of a clavicle fracture that's occurred in this situation. So very, very, characteristic features of high turnover bone disease and these brown tumors. And I just particularly wanted to show the jaw and the clavicle because this is some of these were the bone pain that, well, one of the skeletal pain that this patient was experiencing. Now, adynamic bone disease, on the other hand, although there's not much bone chomping going on, as Prof. Swanepoel would say, the bone goes to sleep. So there's no active calcium and phosphate reabsorption into bone. The bone is just like not doing anything very much. And actually what the problem happens here is that we get serious calcium phosphate milieu in the serum, and then they get, patients get extra osseous calcification. And here you can see examples in the coronary arteries in the heart. One cannot get by without just touching on FGF23 when we talk about CKD, BMD. So I'm just going to briefly touch on it. But FGF23 is the most important phosphate regulatory hormone. Its aim is to excrete high levels of phosphate. And without CKD, what it does, it's a phosphaturic hormone, and it gets rid of our phosphate. However, it increases early in chronic kidney disease, in fact, as early as CKD stage 3. And what it aims to do is it aims to decrease vitamin D to prevent calcium and phosphate absorption in the gut. It also tries to switch off PTH, and its aim is to really try to excrete phosphate in the kidney. So in the beginning stages, FGF23 is really a very helpful hormone. However, what happens after time is that FGF23, its effect becomes not so effective. It attempts to increase phosphate excretion. It attempts to decrease vitamin D activity, and it attempts to decrease PTH secretion, but at some point this does no longer occur, and we get ongoing parathyroid hormone hyperplasia. And we now know that high levels of FGF23 are directly responsible for left ventricular hypertrophy in the heart. So if the calcium and phosphate is being constantly released from the bone, or so in high turnover bone disease, or is not being resorbed back into the bone, like in adynamic bone disease, where does it all go? And we've alluded to this, and it's very important to realize it can go anywhere. So these are some of our patients from our unit. So everybody has their own CKD and CKD BMD problems. And here you can see extra osseous calcification in some fingers. Here we can see another one in the thumb. These are patients that I know too well. Here we can see vascular calcification in the aorta. So also causes medial calcification, quite a big problem when it comes to worsening our cardiac events in CKD patients. So hence all of these abnormalities, those of calcium, phosphate, PTH, vitamin D, the bone abnormalities, the vascular calcification, they all overlap. And hence why we have these KDIGO guidelines on CKD bone mineral problems, because they are all intricately overlinked. And I just want to mention a couple of other things. You can see here that vascular calcification, when there's a calcium phosphate milieu in the serum, we know that the presence of coronary artery calcium is strongly associated with mortality, particularly if it's in the intima, in the setting of atherosclerosis. So we know atherosclerosis is bad for coronary arteries, but we also know when we've got medial calcification, it's also contributory to many of our patients who already have atherosclerosis of the intimal intimal calcification. So our patients, the mortality often have atherosclerotic intimal calcification, include the medial calcification, which is where our calcium phosphate extra osseous calcification occurs, and then we get a double whammy with a reduced survival of worsening cardiovascular survival in our patients. And here's another example of coronary artery calcification. So how do we prevent all of this, which is really where we're coming back to? And there's quite a, there's a lot to be said for a lot of these things, but I'm going to give you some of a bit out of the KDIGO, a bit out of some words of famous people. So how does one prevent progression of CKD bone mineral problems? And I won't forget the words of the nephrologist Jürgen Pflüger, who I listened to once giving this talk. And he says, it's very hard to alter primary prevention. One needs to stay young, they mustn't get diabetes, and sadly, they must stay off dialysis, which isn't very good for our patients, right? So primary prevention isn't going to be very easy for us. So we now have to deal with secondary prevention. So the most important thing is to control the phosphate. And I'm going to come back to Eric's patient and maybe consider whether this patient was malnourished and the phosphate was lower. You said the phosphate was normal, but was the patient malnourished and the phosphate, I won't say falsely low, but actually lower than you would anticipate? So one needs to control the phosphate with dietary restriction. We need to consider phosphate binders. Non-calcium phosphate binders may be better, but they're also expensive. Sevelamer or Renagel is an expensive phosphate binder. We are able to get it in the state sector for the very occasional patients, but also from the words of Jürgen Pflüger, one must get good dialysis. So we must ensure that the adequacy of the patient and the dialysis is as good as we can achieve. We must correct the calcium, but we must avoid calcium loading. We must actually prevent adynamic bone disease, actually, because we mustn't give them too much calcium. So we actually switch off, that we're no longer activating. We're giving them too much calcium. We're switching off PTH, and we're actually causing adynamic bone disease, which I don't believe is the problem in this patient. But we want sort of low calcium dialysate. This will allow us to use active vitamin D to be able to switch off PTH. Perhaps some of the newer analogs may be better, but they're not currently available for use in South Africa. But I'll just give you a little bit of an overview of those now. From a recent systematic review, only 15 randomized trials, but this is the results of paricalcitrol, or one of the newer analogs, and it does seem to favor paricalcitrol for an improvement in an improvement in the hazard use when we use these new agents. And if you look at the forest plot, which actually shows us how it affects parathyroid hormone levels, you can see, although we've got all these trials, they're not actually doing a lot more than what we've got for our own vitamin D at the moment. So I think the jury's still out about whether these newer agents actually are a greater improvement considering the greater cost. So moving right along, I must say, for me, I always think managing trends is really, really important. Trends of parathyroid hormone, of calcium, of phosphate, and actually of the ALP, to see how the bone is turning over. As I've already suggested or mentioned, the KDIGO recommends keeping the PTH 2 to 9 times at the upper limit of normal for the lab test that you use. And we must try to up-titrate our active vitamin D if our calcium and phosphate allows it. And we can do that. I mean, it can be tricky to do that. It's difficult when our calcium is high to up-titrate our active vitamin D. Now, cinacalcet, which was used in our patient, can be used to further lower levels, especially when we have abnormalities of phosphate and calcium, and also if vascular calcification is present. And I'm going to come back to this in a little moment. And then surgical parathyroidectomy should be considered if we're actually failing with all of our current management that we've already attempted. So some other things to address is to treat the acidosis, so to maintain bicarb and to give sodium bicarbonate, because we know that acidosis also worsens our bone disease. And although I can't see the last point on my slide here, I know that it says that we also must ensure that we don't give too much aluminium, because that can also in its own right cause bone disease. So I put I'm just going to briefly, I've mentioned all of these things, but I'm just going to quickly just go over one or two things. We must start thinking about Secondary hyperparathyroidism at CKD stage 3, we must be monitoring our levels, our vitamin D, treating acidosis, phosphate restriction, giving our binders. By CKD stage 4, we want to think more about active vitamin D, consider pericalcitol, although expensive. And as I said, I'm not sure that the results would warrant the expense currently. And then by stage 5, we've got to think about how much calcium we've got in our dialysate. We may need to consider our calcimimetics like cinacalcet, and then parathyroidectomy if required. Now, I will just say a final word about cinacalcet. We know that it works by mimicking calcium on the calcium sensing receptor on the parathyroid to reduce PTH secretion. So in all effect, it's actually trying to trick the parathyroid into thinking that the calcium is higher than it is. Just to mention that calcium sensing receptors are found in the bone and in the gut and in the cardiovascular system. It aims to lower PTH, and it can do so effectively. There is less hypercalcemia in mural models, and in some studies, which we'll see in a second, there's some less vascular calcification. I must say I have used it, as I'm sure many people on this in the audience have. It can cause quite significant nausea. So my recommendation would be to start at a lower dose and just work up as required. And what we do know is that cinacalcet prevents parathyroidectomies, which are not without their own risks. And I think that's important to mention. So just a little bit about the calcimimetics, 2 really major trials when it comes to cinacalcet. The first was the advanced study. And the bottom line for the advanced study is that you can see from this forest plot that actually what it's showing here the progression of cardiovascular calcification, noticing it's cardiovascular. You can see that actually the cinacalcet favors the prevention of vascular calcification in the cardiovascular system. And then the second trial, which moved on from the advanced trial, was the EVOLVE trial. And what this trial tried to show was, were there actually any endpoints, hard endpoints, to show that cinacalcet were benefited, or was there a benefit of cinacalcet over parathyroidectomy? And this was a randomized, double-blinded, placebo-controlled study, with the primary endpoint being death or cardiovascular events. And this study actually found no difference in the primary endpoints. However, it did half the need for a parathyroidectomy. And parathyroidectomies are not without their own problems. So very good for improving PTH levels in our patients, particularly when patients like the one Eric described actually has a lot of symptoms from high turnover bone disease. But parathyroidectomy is associated with a 2% 30-day post-operative mortality. So it's not without its problems, and increased hospitalization in the first 12 months. It can also cause profound, prolonged hypocalcemia due to hungry bones, and it does result in an increase in healthcare costs. So not without its own problems. So I'm finishing my part of my presentation now, and I just want to point out or just discuss some of the things in the presentation, which I really enjoyed, Eric. So thank you very, very much. So I'm going to go back to some important points from the presentation. And I'm going to say that there is, Elliot, are you happy for me to proceed? I think then we can join some, these are some of the major points that I got from the presentation. There is no doubt that this patient has poorly controlled secondary hyperparathyroidism, which has actually become autonomous now. Undoubtedly, the PTH, as I said, has become autonomous. There's no mention about phosphate binders, so maybe Eric might want to talk to me about that. And was the patient malnourished, and therefore was the phosphate low because the patient was malnourished? I'm not sure. A BMI may be useful for the case, just to see how well the patient, the nourishment of the patient. I think it is important to always think, this patient had been on dialysis for 10 years and really probably needed vitamin D, both the substrate early on in conjunction with 1-alpha vitamin D to try to switch off the PTH early in the disease. And I must say, I do empathize with the fact that 1-alpha vitamin D can be very expensive and actually prohibitively expensive in some people in some areas. Now, when I spoke to the surgeon, who's actually a friend of mine, about ultrasound and parathyroid gland, she says it's very difficult. So, you know, the gold standard is really a sestamibi. Not everybody has it available, and we have to, you know, have that as a limitation. She also said to me that actually parathyroidectomies are very humbling. So it is very, very difficult sometimes. It's optimal to take out 3.5 glands. This patient only had 2 glands out. And I have to say, the fact that this patient did not become hypocalcemic post-parathyroidectomy makes me worry that they've left too much behind. So that is a problem. Not to forget that always these surgeries, there's risk of recurrent laryngeal nerve damage. And going back in again for a second parathyroidectomy is also very, very tricky. I can't see what I've written at the end there. I'd also say that perhaps moving forward, there's probably a bit of room to move your PTH in my assay terms. It's actually only 100. It might be worthwhile actually going harder now with the 1-alpha, ensuring that your calcium and your phosphate are well maintained, and rather than risking this patient to another parathyroidectomy, saying that also maybe continuing with the Cinecal set. So I got my radiologist to report on your x-ray because I wasn't sure myself. And also I want one last thing to say is that it's extremely difficult to assess bones without a DEXA scan. So, and we also all don't have that available to us. So we have to do the best that we can. But our radiologist was a little bit worried that there might be some subperiosteal resorption that is a sign of renal osteodystrophy, or in our case, high turnover bone disease. So yeah, I think extremely interesting case, really well done. I always said a lot of hidden dangers, a lot that's going on behind the scenes that we don't see. We don't have the luxury of being able to do all the tests that we want to do when we want to do them. And trends are very, very important. So I think on that note, I'd like to have discussions with, or hear what other people have to say about the case.
All right, thank you very much, Prof. I think it's been enlightening, and I'm hoping that we are all learning something from this interesting case. And indeed, like you mentioned, mineral bone disease is really, really, really a problem. And of course, I mean, because of the cost constraints, sometimes you know exactly what to do on this continent, but your hands are tied to your back. And I think even what Demi mentioned in the chat box, that's something he's also experienced. All right, so thank you very much, Nikki. Eric, it looks like Nikki threw some questions. If you had them, probably just try and answer so that discussion can flow. And I already have a couple of questions. I think, Eric, you've also seen in the Q&A where you can just answer them as we get along. So all on the call, please, if you have any questions, just throw them in the Q&A. So in the next 15 minutes or so, we'll be able to address them. Don't feel shy. And if you probably want to speak out, I will give you the opportunity, but just throw them in the Q&A so we can pick more questions. Thank you. Eric.
Yes, maybe the question that I want to answer is the question about if the patient is malnourished. Let us say that, as I said, since the beginning, since the patient, we diagnosed the patient with CKD, the patient has always have the low phosphate and calcium level. Her BMI is normal. She doesn't seem to be malnourished. Her hemoglobin level has always been good. Albumin always been good, and she was physically fit only till recently, when she started having those really severe pains and as I said, she was limping. She's really painful. Before that, she was really fine. as I also said, alkaline phosphatase, unfortunately, we don't do it routinely.
Yeah.
We do the bone alkaline phosphatase. When possible, maybe we can do the total alkaline phosphatase, but really we don't do it routinely.
So Eric, we only do the ALP, the total ALP. We also don't do bone ALP, just so you know. So just to keep costs down and we monitor trends. Sorry to interrupt. I just wanted to add that.
Yeah,
Okay.
so I still work with, the normal ALP, Eric. Yeah.
Okay. I don't know.
All right, there's a question, so maybe I can guide you, Eric. There's actually a question in the Q&A, and somebody wanted to know whether you removed only 2 glands or all the 4 glands.
Yes, from the surgeon report, they said only the 2 superior glands were removed, but they acted in just on the basis of the ultrasound. So I'm not quite sure that you removed correctly all what was supposed to be removed. So
Yeah, I think speaking to my surgeon over this, I mean, and the fact that there was, as she said, it can be very humbling. It is not as easy surgery. It's not easy surgery. And actually, I saw Julian Jacobs actually said something in the chat. It actually can be useful to do a CT scan. And she also said that to me as well. If you do have CT scan available, that might be useful. But that actually, it sounds to me that they didn't take out enough. They should have tried. Well, I'm not being critical, but it might have been beneficial to take out more than the 2, and the recommendation is 3.5. Saying that, it's difficult.
Yeah, and just to follow up on Julian Jacobs' question. So at the point, was there a CT scan done, or is there a possibility that can be done looking forward?
Yes, the CT scan can be done. In fact, 2 years ago, we had a CT scan, but the report was a bit confusing because in the CT scan they reported some bone fractures that we didn't see. Even on the X-ray, we didn't see all the fractures that were described, and they even described, let's say, that all the glands, this part of the glands were still in positions. So we really didn't know how to interpret or how to consider this the CT scan. Maybe we need to go for another one to see if we can have a better.
Yeah. Okay, great. So I think Yazid, Zayed. Okay, Zayed wanted to know that did you try increasing the cinacalcet dose to, let's say, 60 milligrams?
Yes, but as I said, the problem is really the cost.
The cost. I know. I knew that was coming, but I have to ask it.
Yeah.
In fact, probably be lucky to get a patient even managing a 30 milligram. So, and for what, 1 month and they fall out. So you cannot even sustain it, and that's the situation on the ground. So I actually wanted you to say it. All right, so thank you. All right, and then I think Zayed also wants to know whether, so X-ray is less sensitive. I think there's a comment. X-ray is less sensitive. Did you make DEXA scan? And what about the alkaline? I think this has been addressed already, except you'd want to say something. So guys, let's throw it in the Q&A. It becomes easier to follow, but I see there are a lot of comments in the chat box. So I'll try and go through some of the questions in the chat box. I think there's one from Kaya. So Kaya says, I'm a doctor in DRC, actually in the 4th year of nephrology residency in Dakar. Dr. Nono did not talk about cardiovascular examination, he's saying. In this case, a tertiary hyperparathyroidism, how was the echo? So he's asking whether you did an echo and what was the finding, especially research. I think he's trying to say research into vascular calcification increases mortality in hemodialysis patients. What's your take?
What I can say for this patient is that, as you can see on the X-ray, on the different X-ray that were in the presentation, there was no obvious vascular calcification in this patient. at the level of the transthoracic cardiac echo, it was normal. It's normal. You didn't see any calcification with a normal transthoracic echography. So that's what I can answer for this question.
I have to say, adding to that, it is my experience is that it is extremely unusual. It is extremely variable where the problems happen. So in some people, they get the vascular calcification, extra osseous calcification. Some get the bones. I also think, remember what that adynamic bone disease as well with the calcium phosphate milieu. They tend to get a lot of extra osseous calcification and vascular calcification. So it is really like, I think it just depends on where your vulnerability is. So yeah, really variable, very difficult to know. With this patient, it seemed to be like the bones with the target, the skeleton in the closet with the target, right?
Yeah. All right. So thank you. I think some more questions are coming in now. So what is the role of vitamin D3 supplementation? Is it best daily or one big monthly dose? Nikki.
Oh, okay. So this is a little bit of a tricky one. I think as long as there is an optimal amount of substrate. Okay, let's start with the substrate. So you actually need a proper substrate as long as you are reaching that target. I'm actually not up to date with the actual recommendations, but I think you need the substrate. The second part is the active form. So there is literature to sort of state that maybe alternate days of the 1-alpha vitamin D is probably more physiological. However, I find patients become very confused about the day that they took their 1-alpha, and sometimes just having a daily dose is easier. So what would be my recommendation is that they achieve a good amount of vitamin D, and even if you actually just measure the substrate amount in the blood, even if it's not very frequently, we don't do it very frequently, and try to top up the substrate. And then the 1-alpha vitamin D, actually the recommendation is alternate days because of the way vitamin D actually works.
Great. All right. Thank you. Thank you. All right. So I think Kaya also has a question in here. What treatment for patients with asymptomatic severe hypophosphatemia after parathyroidectomy? Nikki.
Hypophosphatemia.
Phosphatemia after parathyroidectomy. That's the question.
Okay. So the main problem we see is hypercalcemia. I mean,
So I'm struggling here also. I think Kaya mentioned that he's a resident. So except maybe Kaya, you can throw in a bit more. If you've seen a patient who actually had hypophosphatemia after parathyroidectomy, fine, you can just let us know. And like it's been mentioned, maybe you may be needing to look out for other reasons, malnutrition and stuff, to account for why phosphate might be low. All right. And I think
wanted to add, sorry, Elliot, after you finish there, I just wanted to, you finish, and then I just want to, replacing phosphate is sometimes can be a little bit harder than one would choose. So you continue, sorry, I butted in there. I've got a bad habit of it. Continue.
That's fine. That's fine. That's fine. In as much as you give us answers, I'm interested in the answers. So if the answers are coming, I'll keep mute and then you go. So keep on going.
So we always used to have Sandoz phosphate available to us, which was an oral presentation in oral preparation, not presentation, an oral preparation in South Africa, and then it got a Section 21 and very difficult to get. So then the options were potassium phosphate, which actually is not great if your potassium's a problem, right? So so that's also a problem. So then oral fleet enemas is where we go sometimes when we replace phosphate, and actually, to be honest with you, that's what we do often when the potassium is a problem, because we don't have very much available, particularly since they took Sandoz phosphate away. Perhaps someone else can give their solution. That's ours.
I think Robert agrees with you that fleet NMS can be used when you are worried about hungry bone syndrome. So Maza is also saying, and I think we used to use this a lot, aluminium hydroxide, short period of time as a potential phosphate binder when you don't want to jump onto your calcium. So thanks, Maza, for being on the call, and thanks for the comment. So Julian Jacobs also says, I'm an old nephrologist. Julian, it's great to have you on the call. We're taught to find the best parathyroid surgeon, but Julian, what if you don't even have a parathyroid surgeon? What do you do? Whatever you have available is what we use, and that's the typical situation here on the ground. But thanks, Julian, for that. But so if we have more options in terms of surgeon, you go for the best, so far as that is concerned. I think Kudirat, I think I have 5 minutes, and I'm hoping we would work within the hour. So sorry that I'm trying to rush us through. Were the fractures spontaneous or post-traumatic? I think Kudirat wants to know. Secondly, were there any other consideration beyond CKD, BMD for this patient? So I think, no, this is to you. He's asking whether these fractures were spontaneous or post-traumatic, and were there any differentials we considered?
As I said, both fractures were spontaneous.
Okay, all right. So spontaneous.
I did have a thought about that actually, Eric, as well, because I thought to myself, it was quite hectic, those fractures, right? I mean, you know, also CKD patients are at risk of osteoporosis. We mustn't forget about that. I mean, that's the one thing. And then the thought vaguely crossed my mind for a second, just to make sure she didn't have a malignancy of sorts. So they were the other things that crossed my mind, but I think given the whole situation, I think we are dealing with you've got the right diagnosis, but not to forget that osteoporosis is probably contributing here. Although you've said the bone mineral looks okay on the X-ray, we don't really know until we've done a DEXA.
Okay. So I think a comment came on the part of the hypophosphatemia. So if you are struggling with hypophosphatemia, Maza is suggesting that good old Coca-Cola sometimes can help, you know. So it's not always the expensive, fancy drugs. I mean, Coca-Cola would work perfectly with the hope that your patient is not diabetic. So I think that is great, Maza. Thank you for that one, you know. And Ugo also chat is also saying, interesting case indeed. In our center, of course, we have not had any MBDs. Are you sure? Maybe we probably are not looking hard enough, because they really are the skeletons in the cupboard. They are somewhere. The hard you look, you find. You definitely find. But I think Ogo is saying that in most African countries, only calcium phosphate binders are available. You are absolutely right. I don't know if there has been any really been helping our patients, and indeed none of our patients has hypocalcemia regarding correction. I honestly wouldn't want to be in any shoes in managing this patient. You are absolutely right. These patients are very difficult to manage, very, very difficult. And I think that's why Nono was ready to discuss, so we all help Nono in the management. We virtually have 2 minutes. Unfortunately, I cannot go through. And thank you guys. I mean, this is exciting with all your comments and all. We have 2 minutes to go. And I would want to thank Nikki for making time. I mean, the planning towards this has been Herculean, but I think she's been very helpful to get this done. And Nono for making yourself available to be the first. Young nephrologists out there, like I keep saying, you have interesting cases, would want to hear these interesting cases. So you can throw us an interesting case. The next, we are hoping to do this every month, actually, where we hope that any interesting case that you have, let us know about it, or find an expert who will be able to help you. So don't hesitate to reach out to me, to Bianca or Annie, and I'll leave the last minute or so for Bianca, and then maybe a last minute for Letitia for any housekeeping issues. Bianca, over to you. But thank you very much, all of you.
Thanks, Elliot.
Thank you
very much to both of our presenters. I just wanted to, sorry, do you want to share, continue? I just wanted to leave you with one slide, which is just my email address, just so that if you have an interesting case and you're a young nephrologist, we'd love you to email me or Elliot. The whole thought behind this is that we're going to link you up with someone else who's a little bit older and a little bit wiser than us. And it's also a great experience and a way to network and get to know some people on the other side of Africa. So if you have a case and you'd like to be one of the upcoming presenters, please do email me, and we will link you up with an expert within the field. And we are planning to do it monthly. Once again, Eric and Nikki, thank you. And it was a really enjoyable hour.
Thank you very much. Letitia, any housekeeping or?
Just to say thank you to everybody, and if you wouldn't mind completing the short survey at the end of the webinar. Thank you so much.
All right, thank you. Is there a link I can probably share maybe, or is there a way they will get a link, or you send to their mails, Letitia?
It will come up at the end of the webinar once we end it automatically.
Thank you very much. All right, so thank you very much.
Thank you.
Thank you for joining, guys. It's been wonderful. Hope to see you next month.